going to join. And also, I welcome IMA KSB Secretary Dr. Suraj sir, and also all the office bearer Dr. Manjunath Dekar, and today's speaker Dr. Ravi Kiran also. So, shall we start with IMA prayer, sir?
Yes, sir. We'll start.
Yes.
1 minute. Good evening, everyone. Welcome to today's topic. The topic chosen is a very good topic: metabolic dysfunction associated stenotic liver disease. Let us start today's program with IMA prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ವಂದನೆಗಳು.
Thank you, sir. Once again, I welcome all the office bearers. And now it's time to introduce today's speaker. Am I audible, Dr. Manjunath?
Yes, sir.
Okay. Dr. Ravi Kiran, he has completed MBBS from RGHS and MD General Medicine from GR Medical College, Gwalior, India. And again, he did DM gastroenterology from the RGHS. Then he completed MRCP from UK. Then later, he did a fellowship in liver transplantation from Toronto, Canada. So after that, he started his career working as assistant professor in WIMS, Ballari, up to 11. Then later, he joined assistant professor in gastroenterology in Ramaya Medical College, Bangalore, up to 2020. He has a lot of clinical case papers and original articles to his credit. And also he has won many awards, prizes and awards, particularly top score in DM gastroenterology exit examination. And also he was a treasurer of Indian Society of Gastroenterology conference held at Bangalore in 2023. So almost more than 3-4 pages his achievements, particularly the academic case reports and abstract and original articles. So because of the time constraints, with this I'm presenting Dr. Ravi Kiran. So Dr. Ravi Kiran, you can proceed, sir.
Yeah, thank you, sir. It's an honor to be here among you and presenting an important topic on what is now called as MASH. Previously, we called it as NASH. So it is a good thing that IMA is doing this, sort of continued medical education for people. All of us are busy with our practice. So it is important for us to keep updated about different fields also. So let's start this discussion with a couple of case scenarios. So here is one case scenario where 40-year-old gentleman who is asymptomatic who is diabetic on oral hypoglycemic, oral antihypoglycemic, comes to you with the LFT reports. So we see so many people these days coming to you with blood reports, ultrasound done for various issues and or for general checkup. So here is a gentleman who is asymptomatic, 40 years old, comes with you with a slight elevation of AST and ALT. Otherwise, his LFT looks okay. So further going down, his say CBC is normal. So at this point of time, what are the questions we ask? So it is very pertinent that whenever we see a patient with abnormal LFT, we have to ask them whether the patient has used alcohol or not, whether the patient is taking any medicines which can cause. Hope I'm audible well, right? Which can
Yes,
cause
sir.
abnormal LFTs. And
One minute. Yes,
hello.
audible.
Okay. So other things we should rule out is whether the patient is infected with hepatitis B or hepatitis C. So in this patient, the ultrasound is normal with a normal liver spleen, normal liver and spleen. So how do you approach with this patient? What is the diagnosis and what is the treatment? So if this is the case scenario, we have to see what is the level of enzymes increased. So as a hepatologist, I'm more concerned if the level of enzyme increases more than 3 to 4 times the upper limit of the normal. If you are aware, the AST ALT levels are 35. If 35 is the upper limit, okay. If it is above 35, it is abnormal. So if here both of the things are less than 2 times upper limit of normal. So 64 and 656 is not much elevation. For these patients, what we need to do is at least we need to screen. We need to ask for alcohol history, and we have to screen for hepatitis B and hepatitis C and follow this patient. There is as for this, there is no treatment required at this stage. Follow up maybe after 3 or 4 weeks, we can ask his LFT to repeat. So if the LFT is normalized, then there is no further investigations needed. So there is one more case scenario where there is a similar 40-year-old gentleman comes with LFT report, but this time the LFT is a bit on the reddish side. Okay, the proteins and albumin is okay. Bilirubin is 2.6. Direct bili is 1.4. AST/ALT is much more higher now, more than 5 times now, or the upper limit of normal. AST is 132, ALT is 68, alkaline phosphatase and GGT is also increased. So coming to CBC, platelet counts are reduced and INR is 4.5. Again, we have to ask, if we are meeting the patient for the first time, we have to ask the same questions without a miss. So we have to ask if the patient is taking alcohol, medications, hepatitis C. But if you see the LFT already, the LFT is showing a damage to the liver in the form of GGT high, alpha phosphatase is high, and platelet count of 80. So in his ultrasound, he would have shown liver of 17.3, which is there is a hepatomegaly, which is a core echo structure, prominent portal vein. So what we have to know is that with looking at his platelet count, INR, and ultrasound, already the patient is having some sort of portal hypertension along with alkaline phosphatase and GGT. So this is more into the scenario of alcoholic liver disease. Much more sicker patients come with a much more normal liver function test. So these patients can have ascites, bilirubin can be high, the albumin can be low, INR is high, platelet is also low. Ultrasound may show nodular liver and the splenomegaly and prominent portal vein and ascites. So this guy is having decompensated liver disease. So he has lost the chance where he could have stopped drinking alcohol, and no, they could have given a chance of recompensation. So even at this stage, there can be a chance where if the patient stops drinking alcohol, he can have the recompensation of the chronic liver disease. So coming to my subject proper today, which is steatotic liver disease. So this is the MASLD is a new nomenclature which has come up in last couple of years. Previously, we used to call it as NAFLD. If you guys remember, it was called NAFLD, that is non-alcoholic fatty liver disease. But there was a lot of in the West, what happens is they are very sensitive about what patient thinks. When we say that patient is having fatty liver, it is like fat shaming them, body shaming them. That's why they wanted something which is very holistic and which is very exclusive. It is not exclusive, rather than inclusive disease. So fatty liver is called as steatotic liver disease now. So this steatotic liver disease can be caused by MASLD, that is metabolic dysfunction associated liver disease. It can be a part of metabolic liver disease plus alcoholic liver disease, depending on which is the predominant part. It can be the steatosis in the liver can be caused by alcohol also. It can be caused by some drugs. Okay, so steatotic liver disease is a very broad term. In that, we have to know whether the patient is having NASH, that is metabolic associated liver disease, alcoholic liver disease, or MET-ALD, means combination of both alcoholic liver disease and fatty liver disease. Okay, so what are the how do you classify? What is the diagnosis of fatty liver disease? Is that if the patient should have a hepatic steatosis on imaging. For example, if the patient gets a biopsy, patient gets an ultrasound. In ultrasound, they gave it as fatty liver disease. Along with that, he should have one of these 5. That is, these are cardiometabolic risk factors. That is, patient should be having BMI of more than 25. In Asia, it is more than 23. Waist circumference of more than 94 in male, 80 in female. Or if he's having a HbA1c of more than 5.7, or he's diabetic already, or he's having treatment on diabetes mellitus. If the blood pressure is more than 130/85, plasma triglycerides of more than 150, or the patient is on lipid-lowering agent, or the patient is having HDL cholesterol of less than 40 milligrams. So if you see, it is so scary that most of us will be fitting into this category of MASLD. Okay, most of us are overweight. Obviously, my weight is more than, my BMI is more than 23. So I definitely fit it into this steatotic liver disease. So what next? So there are many patients who are diabetic and the fatty liver is there on ultrasound. So most of these patients, most of the people we see are already in the fatty liver disease stage. So what is the prevalence? You can see the worldwide prevalence is 25%. So the most of the people, 1 in 4, 1 in 4% we see will have fatty liver disease. So normal liver will be very smooth liver. There is no steatosis on biopsy. In MSLD, the patients will have a fatty liver with a trivial or no inflammation and no hepatocyte and ballooning. So there will be steatosis, there will be fat in the liver, but there is no inflammation, no hepatocyte ballooning. So in steatohepatitis, that is MASH. MASH is steatohepatitis. So fatty liver is there, but there is a significant inflammation and hepatocyte ballooning. So when this proceeds, there is at the risk 3 to 5%. 25% will have MSLD. 3 to 5% will have it proceeds to MASH, and 1 to 2% are risk of developing cirrhosis. In which cirrhosis they have fibrosis, and it can lead to cirrhosis or hepatocellular carcinoma. So what are the symptoms people will have? People are usually asymptomatic. As I told you, they can come to you with investigations which was done for any other cause. They can have fatigue, and they can have right upper quadrant discomfort. So it can be incidental finding, incidental abnormal LFTs, incidental right liver on imaging, and incidental hepatomegaly. Most common scenario is when the people will have annual reviews in diabetic patients or dyslipidemia patients or hypertension patients who have annual reviews. They can have abnormal LFTs. Patients who are on atorvastatin or rosuvastatin or statins for that matter, they also get annual or biannual LFTs. That LFT can be abnormal. In that way, you proceed with further investigations, and we will come to know that patient is having MASLD. And also, as I told you, patients, many people will get annual health checkup due to medical insurance and other stuff. So what are the steps? So the patient comes to you with a report of fatty liver on the ultrasound. What are you going to do? The first thing is you have to identify whether the patient is at the risk factor of progressive liver dysfunction. So what are the risk factors? So high prevalence group who are at risk of progression is patients who are having diabetes, or patients who are being treated for diabetes, and patients having more metabolic risk factors like overweight, patients having dyslipidemia, patients having polycystic ovarian disease, or the patient having obese, primarily patient having OSA, or the patients who are first degree relatives of the patients who already had MSCLD related liver cirrhosis or HCC, they are also at the higher risk. So we have to, you also have to ask the history of alcohol intake, or whether you have to know whether the patient, whether there is any pre-existing liver disease. So what are the tests you order? So irrespective of the age group, these tests have to be ordered. One is liver function test, which compromises of liver enzymes, AST, ALT, alkaline phosphatase, gamma GGT, albumin, and bilirubin. And you have to exclude any other treatable liver disease. For example, you have to you have to rule out the patients for hepatitis B and hepatitis infection. If they are negative, you have to rule out autoimmune liver disease, and any other causes which can cause rare liver disease for that matter. Okay, so when we speak about the fatty liver disease, so when there are two things in the fatty liver disease. One is the fat content in the liver, and this other thing is the fibrosis of the liver. So what is important? So there was one study which was published in 2015, which showed that this is the fibrosis stage. See, if you can see this, the patients with fibrosis have a rapid progression towards cirrhosis, liver transplantation, and other end goals when compared to the patients who have no fibrosis. So compared to the fibrosis and fat content in the liver, it is the fibrosis which is more important to prognosticate the disease. Okay, here you can see F1 fibrosis and F4 fibrosis. After F4 fibrosis, there is cirrhosis. So higher the chances, higher the rate of fibrosis, the liver related complications will be more, as well as the rate of as well as the death and the transplantation rates. So higher the fibrosis, the higher the complications. You should always remember this. So how quickly it progresses? So if the patient is already having F3 MASH, so already if the fibrosis is F3, it can 22% of the time the people will progress to F4 fibrosis in next 2 years or so, and thereafter they will have a clinical event. So 19% of them will have a clinical event in next 2 years. So from F3 to F3 to clinical event, within the span of 5 years, people will be having more of clinical event. What is those clinical events? So the clinical event can be death, ascites, hepatic encephalopathy, varicose bleeding, new development of new varices. So more than 2-point increase in the Child-Pugh score, or mild score of more than or equal to 15. So basically, when a patient comes to you, you do an LFT, LFT is abnormal, then it is our duty to prognosticate the patient at what stage is his liver disease. Because though we may think that that is the reason why this MASH or fatty liver is called as a silent killer. So even though it may not kill the patient immediately, but in next 5 years, look at the progression rate. So 22% in next 2 years is too much, right? 1 in 4. So if you have seen 4 people, one person in next 2 years will develop F4 fibrosis. So again, in 1 person of 4 will develop chronic liver disease and then clinical event in all these serious clinical events in next 2 to 3 years. So basically, 1 in 4 people in next 5 years will have the severe liver disease if we neglect the people at F3 fibrosis. So this is the one. So you can see the patients there. All these patients are red people are from NASH. So, but you have to stratify, and there one patient is there who is already having advanced fibrosis. So our intention is to find this one person. Who is this one person who can be saved from rapid progression? So there are multiple tests. There are how do you risk factors? I told you before: age more than 50 years, patients who are having diabetes mellitus, and the first degree relatives who had a clinical event. And other risk factors include sedentary lifestyle, intake of high fructose, consuming of more of the Western diet, who are obese and overweight, having metabolic syndrome, people with Asian and Hispanic background, and a patient having dyslipidemia, polycystic ovarian disease, people having some endocrine issues, and people with sleep apnea. So there are different guidelines from the different associations, basically from ASLD, American. So in patients who are having diabetes and who are having MASH, we should prognosticate the patient about the risk of the advanced fibrosis. So basically, increasing number of metabolic diseases is increasing the risk of progressive liver disease. So European guidelines also recommends the same. So you recommend the people who are higher risk, especially people who are more than 50, type 2 diabetes and metabolic syndrome. And American Diabetic Association also recommends the screening or prognostication in the same lines. Okay, so though liver biopsy is the gold standard for diagnosis of any liver related issues, but it has its own limitations. So you can't keep on biopsying of all the patients who come to you with abnormal LFT. So the limitations of liver biopsy include it is of course invasive, it can cause pain, it can be expensive. There is observable variability. One pathologist can what do you say? Can say it is F2 fibrosis. Some other for other people it can be F3, F4 fibrosis. So expertise is important, and it is not practical for screening whole of the population. So this is the what do you say? Imperfectness of the biopsy. So there are multiple other investigations which can supplement or which can be swabbed for liver biopsy. For example, there are multiple scores called APRI score, FIB4 score, MASLD fibrosis score, and there are other patented scores like enhanced liver fibrosis test, fibrosure and APA score, and imaging like transit elastography, that is fibroscan, which has come up very fast these days. Elastography test by MRE, that is magnetic resonance, just like MRI, they do MRE. I think everyone knows this, and MRI, PTFF, and FAST score. So the people, the simple tests are the FIB4, MASLD fibrosis score, and these are very simple, and they can be done on bedside, and they have very good negative predictive value. Means if these scores are negative, that means that there will be no fibrosis. Okay, so these are very good, and of course there are many online calculators which help us in knowing this FIB score and MASLD fibrosis score, which are especially they are in I don't know if you guys are familiar with the QC calculator. In those calculators, all this NFLD scores and FIB4 scores are there. So what imaging we do? So as I told you, this transit elastography or fibroscan has come off late. Every other person who's having fatty liver in ultrasound is getting this fibroscan. It is a low frequency shear wave which is directly shown at the tissue stiffness. So the liver is the stiffer, the faster this wave propagates, and it is a very fast test. It can be done at the background on the OPD basis within 5 to 10 minutes. And one bad part of this is if the people are too obese, this probe is not good enough to pierce that fat. So if the people are having ascites, then also it can give a bad results. So what happens is that it is also having good negative predictive value. For example, if the values are less, it means that there is no fibrosis. If the values are more, it is very difficult for us to tell in which fibrosis score it is. For example, it is ranged from 6 to 12. Okay, if it is more than 12, it is definitely helps to rule in that the patient is having fibrosis. If the value is less than 5 or less than 6, it means that the patient is not having any fibrosis. But for F2 and F3 fibrosis, the fibroscan machine may not be too much helpful. So higher the value, there is higher likelihood of severe fibrosis, and it can predict decompensation and complications. The fibroscan can overestimate fibrosis in patients with hepatitis, cholestasis, liver congestion, and obesity, and also if there is a mass lesion in the liver. So ultrasound can also, there are different ultrasound machines which have come these days, which also can help in measuring the or quantifying the fibrosis and fat content in the liver. So apart from liver biopsy, the most studies which have been found to be useful, better than fibroscan, is the MR elastography. So MR elastography can also help in can also help in making the diagnosis of advanced fibrosis. So what are the common use tests, just to make things clear? So fibroscan is used. It is the most reliable in ruling out the advanced fibrosis. As I told you, if it is less than 5 or 6, there is no fibrosis at all. For MR elastography, it requires radiological reference. It is done, and it is a bit costly thing also. And 2D shear wave elastography, it may require radiology referral, but can be point of care with a minimal training. Okay, so 3 things. One is fibroscan, one is MR elastography, and second is 2D shear wave elastography. So what are the sequential tests? So what we can do is, you can do one test and treat the patient, but we are not sure if the diagnosis is holding good or not, especially when we don't have one single test apart from liver biopsy. So what we can do is, see, this all the, if you do consecutive non-invasive tests, the chances of making the diagnosis will be sure. So we have to have one or two non-invasive tests to make sure that we make the positive decision about the fatty liver disease. So the more tests you include in your algorithm, the more chances are that the chances of missing out of the severity of liver disease will be less. So coming to the treatment part, which is most important. So this is the holy grail, the treatment of fatty liver disease is so difficult, because the resolution of MASH and reversal of hepatic fibrosis takes a long time. So standard clinical trial outcomes include resolution of MASH with no worsening of the fibrosis. So they give the medicine and they see that the MASH is resolved and there is no worsening of the fibrosis, but it takes multiple years. Or the standard clinical outcome is improvement of fibrosis of stage more than fibrosis stage by more than 1 with no worsening of the MASH. So most of the research is on the patients targeted for the pharmacotherapy include the patients who are having MASH stage of more than or equal to stage 2 fibrosis. The crux or the most important aspect of the treatment of this fatty liver disease or steatotic liver disease includes exercise and diet. Okay, so exercise alone can reduce liver fat. You have to have an aerobic exercise of more than 150 to 250 minutes per week, and resistance training of minimum of 45 minutes per day for at least 3 times a week. And in diet, we have to avoid fructose and sweetened beverages and the added sugars. So what has been shown is that there is no need for you to reduce or to come into the normal weight range. But even if you put an effort, so what we have as a doctors, we have to tell patients is, at least put an effort to reduce weight. Even if you reduce weight by just 3%, so if the patient is 100, if the patient comes to 97, so the steatosis rate reduces by 35%. Okay, so if at all the patient is going to reduce weight by more than 10%, so the fibrosis will reduce a lot. So we should not scare the patient who is at 100 kgs and tell him to come back to 70 or 80 kgs, which is humanly not possible without a good effort. So we have to pep them up and we have to tell them that at least reduce 5%, 7%, 10%. So because the studies have shown that even as less as nominal as 3% reduction can reduce the steatosis in the liver. So in the West, the bariatric surgery has come up for all the patients who are obese, but I feel that bariatric surgery is a bit far stretched because at least the people who are able to reduce the weight by diet and exercise, they have to reduce it. But many people are not in a position to do that because of their lifestyle. For them, bariatric surgery is good. So in bariatric surgery, there are a couple of bariatric surgeries what they do, and the most commonly performed bariatric surgery is lap sleeve gastrectomy. So I mean, there are a lot of studies which have obviously shown that the sleeve gastrectomy has resolution of fibrosis in 57%, and also improvement of more than resolution of fibrosis is 39%, and MASH resolution without worsening of fibrosis is 57%. Okay. So how is the histological improvement seen? Histological improvement is also seen in patients who are also on pioglitazone and vitamin E. So few studies have studied with using pioglitazone and placebo, and placebo versus vitamin E. Obviously, vitamin E and pioglitazone score better than placebo with a p-value of 0.04. So the newer drug which has been used in diabetes is semaglutide. So there has to be some FDA approval for this, but of late we have been using this semaglutide for weight reduction in many of our patients. What it has been seen, though it is not FDA approved till now, but semaglutide has been shown to resolve MASH and may improve fibrosis. So to the tune of 59% and 43% respectively. So to summarize, MASLD, as I told you, is highly prevalent. 1 in 4 people will have MASLD with variable rates of progression to MASH and advanced hepatic fibrosis. It is very crucial to identify patients who have MASH with advanced fibrosis, because it can quickly progress to cirrhosis and hepatocellular carcinoma, and the patient may require liver transplantation. Patients with type 2 diabetes mellitus strictly warrant this evaluation of MASLD. Other risk factors include obesity, metabolic syndrome, first degree relative with MASH cirrhosis. Non-invasive prognostic biomarkers may facilitate risk stratification, and lifestyle modification and weight loss are the mainstays of the management of patients with steatotic liver disease. Thank you. That concludes my talk. I'm open for discussion on this topic.
Thank you, Dr. Ravi Kiran sir, for your nice presentation. Even though today, because of multiple meetings, even in Ima and state level, the crowd is less, and highlighting the commonest and increasing trend of the particularly this fatty liver and the management aspect also. So there are some postgraduates. If any questions you want to clarify, you can ask. And our chairman sir also joined. Sir, you are welcome. Join late.
Thank you.
Yes. Any comments, sir, from your side? Please, sir. Chinwala, sir. Anything from your side? Yeah.
It was nice discussion on fatty liver, because most of the things just we are not knowing, only just fatty liver only ways to. But now after hearing the Dr. Ravi Kiran's lecture, so many of the things just we have come to know. To take, especially the diabetic patients, the main obesity and to reduce the weight. So by that one, we can reduce this one, fibrosis and everything, what Dr. Ravi Kiran has told. So we have to not only follow ourselves, most of doctors are also diabetic since long. And we have to follow these things in our life, and also the students, PG students, it will be very much beneficial for them regarding this MASH. Thank you, Dr. Ravi Kiran, for your excellent.
Thank you, sir.
If there are no other questions, Suraj sir, anything is there? Manjunath?
No, sir. Thank you. Thank you,
So,
Dr.
Dr. Suraj, in
Yes.
fatty liver, what are the chances of what are the chances of development into cirrhosis of liver?
So that's what, sir. Yeah. So, I mean, most of us will have fatty liver, sir, especially in India, because especially South India, because we eat a lot of rice. So, and it causes fatty liver. So it not necessarily that all the patients will develop cirrhosis who have fatty liver, but definitely yes. As I told you, we have to know the risk factors. So older age, previously many studies have shown that female are more prone to develop progression. So if someone comes to me with the ultrasound report showing fatty liver, first thing is I will see his age. Second thing is I will ask him whether any family members had liver disease or liver transplantation for any of the liver diseases. Number 3, I will ask whether he is diabetic or not. Of course, these fatty liver people, if they start drinking, the chances of getting progressive liver disease is more. So they should never even touch alcohol if already they have fatty liver. So the chances are there. Whatever the studies I have shown, if the fibrosis is F3. So how do you know if the fibrosis? The best thing is if you have fibroscan, you can do the fibroscan or FIB4 score. What I have told that is available in the App Store or Play Store. You can download. So calculate. Yeah, calculate. Hello.
Dr. Ravikiran,
Yeah.
what is the normal value for the fibroscan?
Fibroscan less than 7 is considered normal, sir.
Less than 7.
Yeah.
Okay.
Less than 7. So once you see what is happening, especially the hepatologist, what we are seeing is many people who are in early 50s, 51, 52 or late 40s, 49, 50, they are getting liver disease. They say, they come to me saying that, sir, I don't drink alcohol, ನಾನು ಕುಡಿಯೋದಿಲ್ಲ, smoke ಮಾಡೋದಿಲ್ಲ, but already they would have come in decompensated state. So it is very sad state that we have not given importance on the diet, especially I mean, our previous generation, it's fine, but we are weaker than our previous generation. I always tell that I am weaker than my father. My father is weaker than his father, and my kids are weaker than me. So this has to be due to the diet. So we don't work as our fathers did, and we don't do as we are not active. We are so much sedentary, and over that we eat too much. We eat too much for that to to expend that whatever we are eating. So the diet has played a very important role, especially I feel in South India it is the rice which we have to limit. So as I mean, once a patient comes to with fatty liver, just don't ignore it saying that it is just fatty liver. At least do some basic tests, do a fibroscan. If it is F4, F3, F4 fibrosis, please refer to a hepatologist or a gastroenterologist.
Regarding the scan you're telling about, is it routine ultrasound suggestive like grade 1, grade 2 fatty liver? Is
Yeah.
it a reliable test or advanced test is required? Because
So
it is
that's
all
what I told you. So see, what happens is these fibroscans or the ultrasound is very good in ruling out or ruling in. See, if the routine ultrasound, what we send for ultrasound, that machine is different, sir. So the newer machines have come, newer ultrasound machines have come where they can do this fibroscan also, elastography also. But routine ultrasound scans, they don't do it. In routine ultrasound scans, it is not reliable. But the newer ultrasound scan machines, if you mention that they can do this fibrosis of the liver, definitely they are reliable. So for example, you have a patient who in normal ultrasound, they have written a as a fatty liver, and you are not sure what stage it is. So you send to the scan with the same ultrasoundologist saying that you want a fibrosis score of it. If he says that fibrosis is minimal, then you are safe. You need not scratch your head. Or if he says that fibrosis is there, then you have at least made the diagnosis that there is a advanced fibrosis. You have to mention, but when you, the basic thing is when you send to the radiologist, you have to mention to to note the fibrosis. If they have a newer machines, they will definitely mention it.
So you mean to say, if fatty liver is detected, if he consumes alcohol, it potentiates the damage more faster and chances of developing cirrhosis. If fatty liver without alcohol, if it is persistent, nothing will happen. That's what you mean to say? Or
come again, sir. Come again.
Sir, fatty liver without alcohol.
Yeah.
Fatty liver with the alcohol.
Yeah.
Okay. The means with the alcohol, he may develop cirrhosis faster.
Yes, exactly.
Thank you.
But that doesn't mean that the fatty liver can't progress, but it increases the progression of the liver decompensation or liver disease.
So if the fatty liver is present, if other risk factors are not there, like alcohol, etc., with regular exercise, there should not be, the chances of reversal is also high.
There.
The
chances of reversal is high and chances of progression is less.
Okay, thank you.
Sir, you're not audible, sir.
Yes, sir. Any other questions, sir, from anybody? Present, sir. Shall we conclude?
Sir, please.
Apart from diet and exercise, what is the any other medication is there?
So what happens is fatty liver was initially seen as a disease which was confined to the liver itself. So the concepts are changing, ever changing. Now it is being seen as a manifestation of a systemic disease. That's why when we see of all the 5 risk factors, even one risk factor is there, then it is a steatotic liver disease. So there is no one drug which can cause reversal of the fibrosis or reversal of the fat, because it is a systemic disease. It is not a single disease. Okay. So there is one drug which is under trial, resomelagon, which I think it may come in next year or so, but it is in a horizon is too far. As of now, if you ask me, is there any one drug? No, there is no drug. But one thing which is for sure is diet and exercise.
Non-alcoholic diabetic, chances of cirrhosis.
So chances of cirrhosis in patients with diabetes is higher if they have fatty liver disease, especially fatty liver disease along with abnormal LFT. So that is the reason they always bifurcate this MFLD as patients with diabetes, patients without diabetes. So patients with diabetes, definitely they will have a progression of liver disease faster.
Sir, one more, my observation is most of the time, even physicians prescribe medication called as Leave 52, something like that.
Leave 52 doesn't work, sir. We don't
it's routinely written prescribed medication.
Yeah.
Miss Easy, do you recommend that tablet?
No,
Any role is there?
No. Leave 52 no role. Silymarin no role. Leave 52 no role. If at all you want to give, I mean, to at least to satisfy the patient, what you can do is diabetes with fatty liver, you can prescribe vitamin E, 400 at international units once a day. And one thing is, other thing what we have to remember is that as the patient gets older, and also the patient is having diabetes and obese, that is also a risk factor for cardiac issues. So it is better to start them on aspirin and statins also. So the what challenge we face is the patient is diabetic, slowly he ages and he develops the decompensation of the liver at 64, 65, and we evaluate him for the transplant, he will be having cardiac disease also. So most of these patients have inherent cardiac disease risk factor. So better if the patient is in 50s, you have diabetes or fatty liver, better to start him on ecosprin and atorvastatin or some statins.
So what is the dose for this vitamin E?
400 international units, sir. 400 IU once a day.
For how many lifelong?
It has to be taken. I give it for a minimum of 2 to 3 months.
Good evening, Dr. Ravi Kiran.
Hello,
Dr. Anuradha here.
Hello, madam.
Fine, thank you. That's what we were asking about prevention or early detection. My suggestion is annual lipid profile is very important.
Correct.
Because when the BMI starts increasing and you have erroneous lifestyle, and then the dyslipidemia happens, that is the time when it's a wake-up call for all of us to rectify prevention of fatty liver is my suggestion.
True.
Thank you.
You're right.
I'm just back from Dehradun CWC meeting, sir. Chindimalzar, sir.
Oh.
I'm in the airport. 2 days I stayed.
We are seeing that, madam. I thought you were in a mall.
No. I'm waiting for the cab pickup. I just got down, fully charged with a lot of information. I'll say during our Raichur meeting, I will share.
Yeah, okay.
Thank you, sir. Thank you. Thank you, Dr. Ravi Kiran.
Thanks, madam.
Thank you, sir. If there are no other things, sir, shall we conclude?
Yeah, Mulki Patel, chosen a very good topic.
Yes, sir.
Especially, it's good.
In fact, credit goes to Dr. Manjunath.
Many other things we don't know.
Short period of time.
Yeah,
Yes,
we have learned many things from Dr. Ravi Kiran.
Yes, sir.
All the best. You continue such topics henceforth
Yes,
also.
exactly. Yes, sir.
Okay.
Thank you, sir. Thank you, Dr. Ravikiran, sir, for
Thank you,
your
sir.
informative talk.
Thank you.
Particularly, it is like alarming for even the practitioner also,
So
because
what
most of the time,
what I would suggest is in the rural areas, no, we don't have much data. So
exactly.
through IMA, what we can do is you adapt a village or something like that, and we will involve young
Screening.
astros, and we can screen those people with fibroscan. We can always take use of pharma companies, and at least as a responsibility of an IMA to make sure that people are aware about this fatty liver disease. So what is happening is even in the rural, because of the industrialization, even the rural people like farmers are also more fat than people from the village from the town. So people there, they just eat and they just don't do work. This is the become the new norm. So we have to make this on the rural setting. I mean, see, in the people who are in Hubli, Dharwad, Bangalore, they definitely they have
Yeah.
access to the doctors.
Data.
But in rural setting, I think we should, as IMA, we can always coordinate, and we can take this as a pilot study or something like that.
Definitely, sir. We'll take.
That's a good suggestion. It's
Yes,
a good suggestion, Dr. Ravikiran.
Thank you, sir.
Dr.
we
Ravikiran, you
will be
mentioned
in
about
touch with you,
fiber
sir.
scan, no?
Definitely, we are going to do some of the camps,
Yeah.
and that time definitely
So
we'll
give me
let you
some
know.
time so that we can come up with
Yes,
a
sir.
good idea, so that it is
Exactly.
for other IMS also it is helpful. So Karnataka can lead in this.
Yes.
Dr. Ravikiran, you mentioned about fiber scan. Is it carryable?
Yes. It is. It is.
Okay.
Fibroscans are couple of this one, sir. For the at least for screening, we have a portable scan.
Okay.
Is a portable scan.
Then it is easy to do screening.
Yeah.
Whether we have to take the permission from the PCP entity, scan means.
So that can be, sir. For now, we generally don't take, because see, the probe is too small. It is like this much probe. ಇಷ್ಟೇ ಇರುತ್ತೆ. So we keep this probe in the intercostal space.
Intercostal space. Okay.
Yeah. So it is very easy, and it is very doable, and before other IMS catch up, we have to do this.
Definitely, sir. Yeah, if there are no other comments or questions, so I thank Dr. Ravikiran, sir, in spite of the busy schedule and small crowd also. So clear many of the doubts, and it was very informative talk. Thank you again on the behalf of IMA KSB and IMA AMS, Karnataka State Chapter. And also extend my sincere thanks to our IMA KSB Chair President, Dr. Chinwala, sir. In spite of his hectic travel, almost like 1 week back only, again he is attending. Thank you, sir, for being with us. And also thank Secretary IMA KSB, Dr. Suraj, sir, for your presence and adding the valuable this discussion. And also extend thanks to Anuradha Parmesh madam, even though she is traveling, most of the times she attends all the online meet. Thank you, madam. So I thought you were in mall. Anyway, thank you. Your
Thank you, sir.
dynamic presence.
And we
And
should thank
also
Manjunath
extend my
also.
thanks.
Dr. Manjunath is forcing all of us to be IMA members, and is
Exactly.
involving us in most of the
Yeah.
IMA.
Definitely.
Yeah,
No,
I
incidentally,
thank
Dr. Dr. Ravi
Alright.
Kiran is I am a member through me.
Yeah.
Oh,
He's
good.
already a member.
Yeah.
Okay. Thank you. Thank you, madam, for bringing such a the active and dynamic person to the IMA. And also thanks to our Dr. Manjunath Dekar, Secretary IMA
Thank you, sir.
KSB EMS. And I thank all our postgraduates who has attended this talk. Thank you once again. Good night.